Good morning, everyone. Today we are going to discuss about advanced diagnostic techniques in periodontics, and specifically in this lecture, we'll talk about advances in clinical diagnosis. So diagnosis, we all know, this is identification of nature of illness by examination of symptoms, and it involves analysis of the case history, evaluation of the clinical signs and symptoms, and also results of various tests. For example, if we want to establish the diagnosis of a periodontal disease, so we'll have to look for probing depth, mobility, radiograph, blood tests, and biopsies if required. And to make a diagnosis, we require diagnostic. So which is a tool, procedure, or a technology that is used in the determination of diagnosis. So firstly, we'll talk about conventional clinical diagnostic tools. So these are the tools which we use in day-to-day clinical practice to make diagnosis. For establishing diagnosis of the periodontal disease, we require periodontal probe to measure probing pocket depth and clinical attachment loss. Along with that, for making radiographic diagnosis, we require a radiograph to assess the level of alveolar bone loss. But these conventional diagnostic tools, so they have certain limitations. That is, they do not tell us about the sites with ongoing periodontal destruction. So rather, they tell us about the destruction which has occurred in the past. Along with that, they do not give any information on the cause of the disease, because periodontal disease is a multifactorial disease. So where bacteria, host response, genetic susceptibility, and other risk factors, so they interplay a role for the disease progression. They do not tell us about the susceptibility of a patient toward particular disease and how well a patient is going to respond to the periodontal therapy. So along with the conventional therapy, we also require immunological assays and microbiological assays to establish a proper diagnosis. So hence, to overcome these limitations, so advances in clinical diagnosis have been made. One such advance is gingival temperature measurement. So we all know that periodontal disease is an inflammatory disease, and whenever there is inflammation, so there is increase in the temperature. Also, increase in the temperature, it is an early inflammatory change which is seen in the gingival tissues. So hence, if we can measure the temperature, so we can detect that there is inflammation in the gingival tissues or the periodontal tissues. For this, there are thermal probes. One example is periotemp probe. So this probe it is inserted into the subgingival area, and it has two light indicating diodes. Once they are inserted into the area, so if the red emitting light diode signals, it implies that the temperature is high, and if green emitting diode signals, it implies that the temperature is low. It is seen that increase in temperature is at the disease site, posterior teeth, as well as mandibular sites, and also with increase in the probing depth, the temperature increases as because of the increase in the metabolic tissues, and there is increase in the blood vessels, in the vascularity, which leads to increase in the temperature. And studies have shown that the sites with higher temperature, so they have greater than twice the risk of future attachment loss. So with this, we can predict that this particular site can further lead to attachment loss in future. So talking about periodontal probes, as per Orban, these probes, they act as an eye of the operator beneath the gingival margin. So it comes from the Latin word probo, which means to test. So these are the gold standard, and they are most widely used for recording changes in the periodontal status. Probes we all know. So they are used to locate calculus, to measure periodontal pocket, to measure gingival recession, to measure the size of intraoral lesions, and to determine mucogingival relationships, etc. But these conventional probing techniques, so they have certain limitations. The recordings of the clinical probing depth, it does not coincide with the histological pocket depth because the probe, it measures the coronal level of the junctional epithelium, and it does not measure till the apical level of the junctional epithelium. And also, if the tissue is inflamed, so this will give less resistance to the periodontal probes, and there can be overestimation of the periodontal pocket measurement. Also, there is lack of sensitivity and reproducibility. That is, there is intra-examiner variability. There is disparity as the probing technique, probing force, angle of insertion of probe, size of the probe. So this can vary among different examiners. So Philstrom, in the year 1992, he classified probes into 3 generations, and in 2000 Watts, he extended these 3 generations to 5 generations. So till now, 5 generations of the periodontal probes have been classified. The first generation is the conventional probe. So these are the handheld instruments. The disadvantage is that they do not control for probing pressure. So this could lead to bias or disparity because of intra-examiner variability. The example of a conventional probe is Williams probe. So this is the probe which is a prototype of the benchmark. It has Williams marking. It has calibration still 10 mm in which 4 and 6 are missing. So then there's another probe which is known as Community Periodontal Index of Treatment Need. So it is 5 gram in weight and it has a ball tip of 0.5 mm. It is further classified into two types, CPIT and E probe, which has color coding at 3.5 and 5.5 mm, and CPIT and C probe, which is usually used in the clinic. It has color coding at 3.5, 5.5, 8.5 and 11.5 mm. Then there is University of Michigan O probe, which has color coding or calibrations at 3 mm, 6 mm, and 8 mm. Then there is UNC 15 probe, which has calibration still 15 mm and color coding at 5, 10, and 15 mm. There's Neighbors probe, which is used for assessing percussion. The advantages are they are easily available, they are inexpensive. The tactile sensitivity is preserved since they are handheld. So even in the presence of subgingival calculus, the probe can be inserted with little navigation by the operator. The tip is round to avoid any trauma. And also it is color coded for easier and faster identification of readings, but it has certain disadvantages. They are heavy. And the most important disadvantage is the probing force is not controlled. So tip of the probe may pass beyond the base of the pocket. So there could be errors during visualization of the readings, and also assistance is required to transfer the data to the chart. To overcome these limitations, the second generation probes were made. So this is known as constant pressure or pressure sensitive probe. So as the name implies, pressure sensitive or the constant pressure, in this, they are pressure sensitive. So they have pressure control. The pressure should not exceed 0.2 newtons per millimeter square. One of the example of this generation probe is true pressure sensitive probe. So it has a disposable probing head and it gives the pressure of 20 grams. It has a diameter tip of diameter of 0.5 mm, and it uses a small piezoelectric pressure sensor which is attached to the non-probing end of the probe tip. There's another example is pressure probe, which was given by Walter Weldon in the year 1978. It has a cylinder and a piston to control pressure. One more example is electronic pressure sensitive probe, which also allows for control of pressure, and it was introduced by Paulson in 1980. One of the modification of this probe given by Paulson is Yeppel probe, so which is used in studies of dentinal hypersensitivity. Another example is a simple constant force periodontal probe, which uses a stainless steel spring to generate constant force. So it has been seen that within the force of 30 grams, the tip of the probe, it remains in the junctional epithelium. And if the forces exceed to 50 grams, so we can diagnose the osseous defects. So coming on to the advantages of second generation probe, the most common advantage is that there is standardization of the probing force. So there are chances of bias are reduced. It is comfortable to the patient and there is constant pressure, but still it has certain disadvantages that the probe tip, since the tactile sensitivity is lacking, so the probe tip may pass beyond the junctional epithelium in the inflamed site. And again, since it is non-automated, so recording has to be performed manually and assistance is required to transfer the data to the patient chart, and there is no computer storage of the data. So to overcome these limitations, third generation probes were developed, which are also known as automated or computerized probes. So they have controlled force application along with that automated measurement and computerized data storage and capture. So this reduces examination or examiner bias. The prototype is Foster-Miller probe. So this is the probe which is capable of automatically assessing or detecting cemento-enamel junction, which can be used as a reference point to measure clinical attachment level. Another example is a Florida probe system. This is also a constant probing it uses a constant probing force. It has a sleeve edge, precise electronic measurement of 0.1 mm. So this has a foot control. It has a computer system attached to it. And it also uses the gingival margin as a reference point. And then there can be sequential recording and of clinical attachment level, the relative clinical attachment level. One more example is Toronto automated probe, which uses occlusal or incisal surface to measure relative clinical attachment levels. Another example is Acutech probe. Then there is interprobe, which is also known as perioprobe, and this is a third generation probe which has a flexible probe tip. The advantages are this: there is standardization of the probing force. So errors in reading the probe and transferring the data are eliminated since it is automated, and printout of the data from the computer can be used to educate the patient. The disadvantages are the tactile sensitivity is decreased, so probe may pass beyond the junctional epithelium in the inflamed site, thus overestimating the pocket depth. Then we have fourth generation probes, which are also known as three-dimensional probes. So these are currently under development. The advantages are three-dimensional probe. So there is sequential probe positions. The probe is used in sequential probe positions, and it gives a wide area for the diagnosis. But the disadvantages are this is under development and it is an invasive procedure. Then we have fifth generation probes. So they are three-dimensional probes, but they are non-invasive because they use an ultrasound or other device that is added to the fourth generation probes, and thus making it more advantageous and less invasive. So the aim is to identify the attachment level without penetrating it. So in this generation, the only available probe is the ultrasonographic probe, which uses ultrasound waves to detect, image, and map the upper boundary of the periodontal ligament. Here, we do not need to touch the tissues because of the ultrasonic waves, so they can gauge the upper boundary of the periodontal ligament, and also the variation which is occurring over a period of time. This is an indicator of presence of periodontal disease. So this is a fifth generation probe. Here we can see this is a contra-angle handpiece which has a transducer device which emits ultrasonic waves, and this is a non-invasive probe. And here we can see it has a foot control, it has a water control system, and this is attached to a computer. The advantages are it is a non-invasive probe that provides painless probing to the patient. There is no question of probe passing beyond the junctional epithelium as it is not touching the tissue, because the ultrasound waves, they detect, image, and they map the upper boundary of the periodontal ligament. Along with that, there is computerized storage of the data, and printouts or visuals can be used for patient education. The guidance path is predetermined and provides information regarding condition of the gingival tissues. The disadvantages are it is expensive and the operator needs to understand the images provided by the computer, and it requires a learning curve. So it is not that convenient to use, and it is quite expensive also. So these were the advances in the clinical diagnosis. So in the next lectures, we'll further cover the advances in the radiographic diagnosis, in the microbiological and diagnosis, and so on. Thank you so much.